Thanks for the introduction. I will talk about the new and developing treatment modalities for sickle cell disease. I would like to thank the organizers of this conference for the invitation to speak and the participants for making time to join. I will touch briefly on the 3 latest treatment modalities licensed for sickle cell disease and end the discussion by talking about multimodal therapy. Much of what I have here is generally known, but the point is that if sickle cell disease is caused by a genetic defect, it is possible to cure it by gene therapy or stem cell therapy using stem cells which carry the normal gene. However, short of making sickle cell disease go away completely or cure, treatment can make the condition less severe by reducing any of the 3 main things the condition does to harm the body. These are premature destruction of red blood cells, which will lead to anemia, obstruction of blood vessels, which reduce the supply of oxygen and food to various parts of the body, causing damage, or weakening of the body's defense system, which makes the affected person susceptible to infections. Multimodal therapy is simply treatment that reduces 2 or more of those 3 main things which sickle cell disease does to harm the body. The first treatment modality I will discuss is glutamine. It is an amino acid, which means that it is one of the building blocks of proteins. Glutamine works by helping the body preserve biologically important molecules such as hemoglobin and omega-3 fatty acids in the membrane of blood cells. That way, it reduces sickling and the destruction of blood cells and ultimately raises the hemoglobin level and improves the clinical condition of people affected by sickle cell disease. It was licensed on the 7th of July 2017 by the US Food and Drug Administration. I'll move next to anti-addition molecule therapy, which is exemplified by crizanlizumab. There are glue-like materials on the surfaces of blood cells which make it possible for them to stick to each other and to the blood vessel wall, thereby blocking the flow of blood. So substances which reduce the action or the amount of these addition molecules are used to treat sickle cell disease. These molecules, when blocked, have a beneficial effect because indeed previous research by our team had shown that sickle cell disease patients who have a higher than usual amount of these addition molecules on their blood cells are more likely to develop complications such as stroke or kidney failure. In addition, it was also shown that during crisis, the amount of these molecules on white blood cells in particular rises by about 7 times and then returns to baseline when the crisis is resolved. It is important to bear in mind that apart from the monoclonal antibody already licensed, other blockers of selectin in particular may be more affordable and convenient, such as the ones that can be taken by mouth and the ones that are cheaper. So we need to keep searching for the ideal selectin blocker. Voxelotor is the 3rd one I will briefly talk about. It was granted accelerated approval by the US FDA on 25th of November last year for sickle cell disease patients of age 12 years and greater. It binds to and stabilizes the oxygenated hemoglobin. And since it is deoxyhemoglobin that has reduced solubility and causes red cell sickling, Voxelotor ultimately has anti-sickling effects, increases hemoglobin level as was found in the initial clinical trials, and ameliorates anemia. The concept of multimodal therapy was developed in an attempt to combine the effects of various agents which act by single mechanisms. The idea being that there might be an additive or even multiplier or synergistic effect. This multimodal approach to specific treatment of sickle cell disease is akin to combination chemotherapy of cancers with cytotoxic drugs, each of which inhibits cell division by a different mechanism. Several studies, for example, had shown that omega-3 fatty acids are beneficial in sickle cell disease. They confer clinical benefit because they reduce the amount of these glue-like materials from blood cells. They also reduce the number of painful episodes of crisis and complications. And I've shown data from several of those studies in this particular slide. However, if one wants to improve on the clinical benefit of omega-3 fatty acids, it is possible to combine them with another agent which acts by a different mechanism. So in the University of Nigeria Teaching Hospital in Enugu, we combine these acids with the anti-sickling agent, potassium thiocyanate. Together, the combination inhibits 3 of the fundamental mechanisms of sickle cell disease: vessel occlusion, sickling, and hemolysis, and so has the potential for greater clinical efficacy. It is pertinent to note that hydroxyurea, which was the first drug licensed for sickle cell disease about 23 years ago, actually works through multimodal effects by reducing premature destruction of red blood cells and therefore anemia, as well as reducing those addition molecules that enable blood cells stick together. Hydroxyurea also, as we've shown in previous presentations today, reduces the number of blood cells themselves, platelet count, white cell count, and therefore reduces the tendency or the likelihood of cells to block the blood vessels. Let me just say that I had hopefully timed this presentation to be less than 10 minutes, and that I would like to profoundly thank all the sickle cell disease patients who have participated in the mentioned research studies designed to better the understanding and treatment of this condition. I would also like to acknowledge and thank the various researchers in different countries who did the studies with me, and my family for support that words cannot really describe. I would like to thank you all for listening. Thank you.